Everyone, this is Haddock, the medical editor-in-chief for ACEP Now, and with me today is Dr. Alison Haddock, who is the president of the American College of Emergency Physicians. We're here for our semi-annual talk with the president. Dr. Haddock, thanks for joining us today.
Yeah, good to be here.
I was there at your remarks as president back in the ACEP Council in Las Vegas, and you mentioned to the listeners and the council that you wanted to focus this year on physician autonomy. Can you explain that to our readers, what you mean?
Yeah, when I look at what's happening in emergency medicine right now and try and connect the threads of all of the stressors that we're experiencing, a common thread that I see is that we are physicians, we are experts, we are incredibly well trained, we're ready to take on anything. We are not being given the resources and the choices that we need to take excellent care of our patients. And that to me boils down to a lack of autonomy. If we have access to what we need, we can take better care of our patients. That means having access to insurance coverage for things like discharging someone to a SNF. That means access to all the medications we need and not facing all these drug shortages that we've been facing. It means having a say in our workplaces about how they're staffed and what the expectations are, not just for us as physicians, but for our colleagues in other spaces, making sure we have access to the expertise and the hands that we need to take care of our patients. And I really think it's that loss of autonomy that's causing the distress and the burnout that we're seeing in emergency medicine right now.
Well, that's actually what I wanted to talk about next, because in multiple surveys from Medscape, for the past 3 years, in fact, emergency physicians have led all physicians in their scoring for burnout. What is the college doing to address that?
In my opinion, the cause of that is the lack of autonomy. We have less autonomy than all the other specialists in the House of Medicine because other folks have different resources and different ability to kind of have their own practice and choose their own style than we do. So, if you're a neurologist, you have the ability to go set up your own neurology practice, hire your own staff, decide what kinds of insurance you're going to take, and make all these decisions that we just can't make in emergency medicine because of the systems and because by being emergency physicians, we're tying ourselves predominantly to working in a hospital. There are some freestanding EDs that have been privately owned and have flipped that on its head a little bit. And there's advantages and disadvantages to that. And one of the reasons I think those are something important to look into is the autonomy that they offer us as physicians to own our own space and control those factors that are otherwise outside of our control. But in my opinion, the core of improving that is greater autonomy, greater control over our schedules, greater control over our lives, so that we can feel like we're getting that work-life balance that we deserve for all of the training we went through, all of the 80-hour weeks that we worked. We should be in a place where we're treated like professionals and have the resources that other professionals have.
Well, one thing I'd like to talk about that I think has influenced a bit of the autonomy in our profession. We published a piece in ACEP Now about the role of private equity in healthcare. And according to Ivy clinicians, they say that about 25% of US emergency departments, the clinicians are managed by private equity owned firms. My question to you is, do you think that private equity needs to get out of the business of emergency medicine?
I think it's a little bit of a difficult question because there are like every hospital is individual, and there are some well-run hospitals that may have some degree of private equity involvement, and there are some poorly run small democratic groups that aren't necessarily, treated well by their hospital and able to offer what they want. However, I will say, broadly speaking, private equity is not holding the interests of patients or the interests of physicians at the top of mind. Private equity, the business model of private equity is to briefly invest in something, extract as much profit as you can during that brief investment, and then get out. And that's not a kind of model that is patient focused or physician focused because it's only about extracting dollars. And so I don't think that that is a model that's well suited for healthcare in general, because healthcare should be about putting patients first and then putting the caretakers of patients second. And that's not what private equity is doing. And honestly, it's not what most insurance companies are doing either. And that's why we're seeing burnout. That's why we're seeing patients who are so dissatisfied with the healthcare system. That's why we're seeing the problems that we're seeing in healthcare today.
And I think on a related note, a lot of emergency physicians seem to be growing frustrated with so-called contract management groups, which are sort of larger organizations that are trying to run the business practice of emergency medicine across multiple hospitals, sometimes multiple states. Do you agree with the frustrations that we hear from members and other emergency physicians out there? And if so, what do you think ACEP can do about that?
I think that there is a lot of frustration with a variety of physician employers. And so that's part of why ACEP is working to increase transparency in this space and restore physician autonomy. Because I think the reason why people are frustrated with employers is because they're not being given the autonomy they need, that they don't feel fairly compensated. They don't feel like schedules are fair. They don't feel like they have control over the resources they need. That's really what's driving the dissatisfaction with physician employers is the lack of autonomy. So I think we need to pressure all kinds of employers to offer more autonomy. That CMGs are part of the problem. So are giant academic groups where you just have such a huge group size that the power is like not localized at all. It's all centralized. And so the folks on the ground who are living the life and seeing the patients aren't able to talk to the folks who are making the decisions and say, hey, this is what's going wrong. And this is what we need to take care of our patients. So I think it's important for ACEP to help be that voice for those physicians, and also to encourage employers of all kinds to offer transparency about how they do their business, how they follow ACEP policies or don't follow ACEP policies. And so that's one of the drivers of ACEP Open Book is to have a place where you can go when you're looking for a job to say, hey, does this site, does this employer adhere to ACEP policies that are intended to protect the emergency physician?
And again, like you said, the academic groups sometimes can be similar to these large mega groups, but even still, physician-owned groups are not immune to these kinds of difficulties as well. And one of the major things happening, sort of breaking in the news cycle now, is that a particular group, NES Health, has had some difficulties with financial pressures paying their employees. And what do you think is the outlook for the business of emergency medicine when we're seeing these disruptions happening all the way from sort of the larger groups to even the physician-owned groups?
What happened with APP was absolutely unacceptable, where people were left without malpractice tail coverage due to group transitions and issues, again, at levels that were way outside of their control. And I just hope that we don't see that same thing happen with NES. But it does show that this is happening across models of providers of emergency medicine, physicians, emergency medicine services, because those have two different kinds of business models, with APP having more private equity involvement and NES being more like individual physician led. So part of what's driving all of this is consolidation in the healthcare industry on the whole, which means consolidation of hospitals and consolidation of insurance companies. And a lot of what's driving consolidation of employers is the fact that to be able to fairly position yourself and negotiate with these mega conglomerate insurance companies, you need to have a group of a certain size, often, to be successful in those negotiations. So I believe we need to be looking at consolidation across healthcare because I think it's having negative consequences on multiple levels, not just the insurance company level, not just the physician group level, but all of these levels. They're decreasing the amount of choice that patients have, and they are leading to imbalances in the marketplace. And we already face a dysfunctional marketplace because of EMTALA, which means that we will see everyone who comes through the door, regardless of their insurance coverage. You can't set up an emergency department and say, hey, we don't take Medicare and Medicaid in a hospital. Hospitals have to participate in Medicare. They have to accept these kinds of insurance. There's EMTALA mandates. And those mandates are really important to protect our patients. And I think we're a driver for a lot of us to go into emergency medicine, but they also create a very unusual negotiating environment in terms of the free marketplace that we generally try to have in healthcare in America.
All right, well, thank you. One thing, I've known you for a long period of time now, and in our conversations, you've always stressed to me your concern about membership for the college. And I often will talk to people that aren't members but are emergency physicians. And one of the things that they ask me when I am wondering why they're not members is, what is ACEP doing for me? What would be your answer to them about what ACEP is doing for them?
We are constantly trying to empower our members, protect our members, and make the practice of emergency medicine better. So there is such a huge spectrum of things that we're doing. I think some of our most important work that we're doing right now is around the Open Book Project and creating policies that define what a good workplace looks like for emergency physicians. The reimbursement work that we do is critically important. We're representing you at the RUC and trying to make sure that the RVUs for the services that we provide in emergency medicine are fair. But we're just representing at all the levels. It's not just at the RUC. It's also going to Congress. It's also having conversations about balanced billing and the dispute resolution process. And then it's also at a more individual level at looking at how we can make each individual emergency department better for both patients and physicians. We have a really successful geriatric emergency department accreditation program that looks at making sure you have the resources you need to take care of elderly patients. And we know that that program has led to things like having walkers available in EDs and having actual food for patients instead of a vending machine available in EDs, and that those things make a difference for you in terms of being able to provide resources for your patients. And now we're looking at the next level. Can we accredit emergency departments just broadly and have even better requirements in terms of what it requires the workplace to offer you as a physician and offer you in terms of resources for your patients? The last point I will make is boarding. Boarding is crushing us all in emergency medicine right now. It is absolutely an example of that lack of resources that doesn't let you be the kind of doctor that you want to be, that you went into emergency medicine to be. And we're doing critical work now advocating with the AHRQ and the federal government, trying to take action on boarding so that hospitals are under more pressure to solve boarding, because we know it's not an emergency department problem. It's an entire health system overload problem that needs to be solved on a higher level. So that advocacy is just something that you can't get anywhere else other than ACEP. And so I hope folks will recognize that and become members so that they can participate in that and get a better workplace for themselves and their patients.
I think, as a follow-up, one of the difficulties with that is there's this concept called the tragedy of the commons, where people benefit from things that, the ACEP members are actually paying for, even if they haven't paid for it themselves. Like the wins with the RUC, in terms of our reimbursement, whatever wins we were able to get through the college as it pertains to boarding, having a boarding summit at AHRQ. How do you counter that mentality of people that want to stay outside of the organization, because they feel like they'll get those benefits anyway, as opposed to people that want to stay dedicated and continue to contribute to an organization?
Well, I definitely ask them to come join to be part of the solution, not just let the solution happen to them, but be a part of creating it. I think that there are tons of ways to have your voice heard within ACEP as well. You can participate on a committee, you can participate in a section, you can become a counselor. And so there's ways that you can not only just like sit back and watch those good things happen, but you can participate in implementing them and prioritizing them in a way that lets the best things happen.
We're recording this the Friday after the presidential elections, and our country right now seems somewhat divided, maybe quite frankly. I've seen where a lot of the opinions put forth by our ACEP members on multiple issues, whether it's reproductive health care, diversity, equity, inclusion, or other broader societal issues, seem to differ drastically. We receive these letters to the editor, we get opinions, and sometimes they represent various poles. How do you, as president, plan to navigate these issues, which pit some members of the college in opposite camps from one another?
These are definitely really challenging spaces for us to be in. But I think we need to focus on putting our patients and our practice first. So you can have a variety of opinions on something, and maybe it doesn't really touch us in emergency medicine, but we need to look at the spaces where it does engage us as emergency physicians, and how can we make sure that physicians are protected and able, given the resources that they need to provide the care that they need. So for an example, Medicaid expansion can be a somewhat politically polarizing issue. However, when you look at reimbursement for emergency physicians, it's generally seen to improve with Medicaid expansion. And so we offer resources to states, and we have a policy in support of Medicaid expansion because that seems to get better compensation for our emergency physicians and offer better coverage for our patients. But we also offer those at the national level for the states, but then states can choose to do what they wish with those. And I think that gives us a little level of independence too, where folks at a more local level are making the decisions that are right for them.
Well, thank you. That's all I had to ask you today. We'll meet up again in a few months after you've had a chance to sit in the seat, or the hot seat rather, and we'll touch base sometime in the spring or summertime to see how the rest of your presidency's gone.
That sounds great. Thanks so much. Great to see you today.
All right, good to see you as well. Thank you very much.